Recording in progress. Hello, this is David G. Armstrong. I am the founding president of the American Limb Preservation Society, and I welcome you to what I think is just going to be an absolute, just an absolute treat academically, but also, I mean, it's really the spirit of what ALPS is all about. For those of you who don't know what ALPS is, you're going to learn about that from Georgia Krehbiel, my longtime friend and now the founding CEO of ALPS. But ALPS really is basically a cross between a dating app and a marriage counselor for women and men that want to eliminate preventable amputation over the next generation. Doesn't matter who you are, where you train. We are agnostic to that, but we are evangelical about eliminating preventable amputations, and putting people together is what it's all about. And interestingly, this entire webinar is focused on bringing the toe and flow together like never before, because if we do that, then this potentially a revolutionary intervention in formerly no option patients may have great promise, really, in helping patients and eliminating amputation. So it's my pleasure now to introduce my friend and soon to be yours, the lovely and talented Ms. Georgia Krehbiel.
Thank you, Dr. Armstrong. So hi and good afternoon or evening, depending on where you are. Thank you for joining us for today's most important webinar presented by Inari and LimFlow. I'm Georgia Krehbiel, CEO of the American Limb Preservation Society, also known as ALPS. As David said, at ALPS, our mission is to eliminate preventable amputations through multidisciplinary education, care, innovation, and collaboration. And today's session is part of that commitment, bringing together leaders in the field to share insights, strategies, and technology for advancing care for patients with chronic limb-threatening ischemia. We are especially grateful to LimFlow for their support in this educational initiative. Their continued investment in clinician education, patient-centered innovation is helping to change the landscape for no-option CLTI patients. We hope this webinar sparks new ideas, strengthens your clinical approach, and reinforces the powerful collaboration in saving limbs and lives. If you are not a member, or if you need to renew your membership, we would like to offer a special, AK, if you would switch that, we would like to offer a special code, and if you would scan that QR code, put in the code CLTI, and that would be good for $1 for 1 year for membership. So please consider joining us. If you have any questions, would like to reach out, feel free to. If you'd like to get more involved, we would be happy to have you on board, and as Dr. Armstrong says, part of the team. I will now turn this over to Dr. Brian Lepow with Hope Vascular and ALPS Founding Treasurer.
Hey everybody, how are y'all? Dr. Brian Lepow from Hope Vascular Podiatry here in Houston. Also founding treasurer, as Georgia mentioned, of the American Limb Preservation Society. Tonight we really have a great event for y'all. This is our inaugural webinar series that we'll be kicking off today with the sort of the kind gesture from Stryker Inari LimFlow. And the topic we'll be discussing is deep vein arterialization. It's one of the unique, I think, opportunities that we've had as of recent in practices of both vascular and podiatry, where the interdisciplinary team is critical to the success of these patients. I've had a lot of experience with this, as our distinguished panel has today, so I'm super excited to dive right into this. I'll give a quick introduction to our esteemed panel. We will kick things off with Dr. John Evans. He has been a podiatrist for over 37 years and is in private practice in Southeast Michigan, chief of podiatry at the Beaumont Hospital and Medical Center in Dearborn, Michigan since 2000. He's a chair emeritus of the APMA Health Policy and Practice Committee and has served as a Medicare Carrier Advisory Committee for over 20 years. He's a 2018 recipient of the APMA Award of Excellence and presently serves as the podiatric representative to the American Cardiology Association and the American Heart Association. Following Dr. Evans will be Dr. Laura Shin, who needs no introduction, who is now an assistant professor, soon to be a rising professorship at Keck School of Medicine at USC. Her interest is in limb preservation, but also in stem cell biology and potential for using stem cells to repair diabetic wounds. Along with her passion for care, this led her to pursue a dual PhD and a DPM degree. In her clinical research and her pursuits, she has dedicated her career really to the passion of limb preservation and works with a fantastic team down at USC, and she will be covering the topic of best practices in post-TADV wound care. And then slotted right in between the two is the great Dr. Siah out of UT Southwestern. He's the assistant professor of the Department of Surgery and the director of limb preservation services at UT Southwestern Medical Center in Dallas, specializes in vascular surgery. He's earned his medical degree at University of Hawaii and has completed his residency of vascular surgery at Georgetown. He's worked in several tone flow centers and has been doing a fantastic job, not only leading the way in deep vein arterialization at his hospital, but also globally. And we're really fortunate to have everybody here to share their experience. So we'll look to get this kicked off. I ask anybody who has questions to please pop those in the chat, and we will do our best to answer anybody's questions as they come up. More than likely, we'll cover those at the end of the session here, time permitted. So with that, we will kick things off, and I'll hand things over to Dr. John Evans, where we'll get started.
Thank you, Brian. So tonight, we're primarily going to be talking about chronic limb-threatening ischemia, this most severe aspect of the spectrum of peripheral arterial disease. But first, I'd like to step back a little bit and basically talk about the state of PAD as we know it in our society today. It's extremely common, although it's under-recognized. Over 230 million adults have it across the globe. In the US alone, the numbers could be as high as 26 million of us have PAD. The costs are staggering. Well over $340 billion a year are spent on treating this disease. It's associated with a number of other disease processes. The atherosclerotic processes such as coronary artery disease and cerebrovascular disease, there's a high degree of interchange between that and peripheral arterial disease. Certainly patients that have diabetes, this is a major problem for. Those who have high blood pressure or lipid disorders are on the spectrum for it. And certainly we see it a lot in patients who have renal disease. But probably the most important driver of this condition is smoking. This used to be called critical limb ischemia, but now it's chronic limb-threatening ischemia. It's the same disorder, but of the whole PAD spectrum, it makes of these patients, which could very well be over $3.8 million for patients a year. Of these, we unfortunately have to deal with about 150,000 non-traumatic amputations each year in the US. So it's an under-recognized disease process, basically because we don't even know it's there until it reaches a symptomatic stage. The research has shown that the disease process actually begins in our teenage years and gradually progresses. But if we don't recognize it as being a disease, which means it's not symptomatic, we don't treat it. So unfortunately, we have to deal with the repercussions that we have now. And next slide, please. CLI is defined by a severe level of peripheral arterial disease that includes patients with rest pain, gangrenous changes to the foot, or a lower extremity wound that is greater than 2 weeks in duration. Now, patients who fall into this category are at great risk. We also know that every 2 minutes, a limb is lost due to ischemia between the United States and Europe. So it's an incredibly dangerous disease process. And it's also deadly. We know that CLI and CLTI are as dangerous and have as high a mortality rate as most disease states, including almost all the cancers, except possibly lung and pancreatic. When it comes to amputation, within 4 years, between 1/3 and 2/3 of patients will undergo an amputation. And at year 1, 20% of these will have died, and by year 5, up to 60% have passed away due to this disease order. I'd like to talk a little bit about what we have right now in our society. This article was recently published that looked at Medicare data from 2017 of patients who had CLTI and a foot ulcer and underwent an amputation. Of these patients, almost 2/3 received no revascularization in the year prior to their amputation. Over 90% of these patients did not receive an angiogram before they took the leg off. And when they had an amputation, almost half of them had above knee amputations. I mean, this is chilling. This shows that we really are not recognizing this disease before it gets to a level that causes problems. And when we get to patients who are at that level, we're really not looking into what other options are available for us. Something that's often overlooked is something called small artery disease. We tend to be able to identify patients who have poor arterial flow. One of the vessels below the knee, or all of them, could be blocked. But small artery disease is a little bit different. These are the patients, when you take an X-ray of their foot, their whole arterial anatomy shows up, and you can see it visibly, which you otherwise should not be able to do. So patients who have this have a dysfunctional oxygen transport system in the foot because the capillary beds are not working appropriately. So these patients really are not cured by using a lot of the amazing techniques we have for interventions, such as angioplasty or atherectomy. And unfortunately, patients who have this level of disease state tend to have continued wounds and are at a really high risk of amputation or death within a year. And of those patients who survive but have an amputation, 10% will die before they're discharged from the hospital after an amputation, and up to 70% of these patients are not alive in 3 years. So having an amputation is not very healthy for the patient. There's a certain category of these CLTI patients that we consider having not being eligible for any of the conventional surgical or endovascular interventions that are usually available. They have no named pedal vessels that are available to either bypass to or to clean out the arteries to increase the blood flow. And they may have this severe calcification of the arteries that really leads to a dysfunctional capillary exchange system. These patients are often called no option. Those of you that treat feet and legs will recognize this as patients who you have referred out for vascular consults, and they come back in your practice saying there's nothing they can do. Basically, they're told to wait until they're ready to have an amputation and then do so. Unfortunately, there's about 264,000 new no-option patients every year. And about a third of these no-option patients who are alive and amputation-free at 1 year, the mortality rate is terrible, with about 50% by 1 year. So patients who have no option really are looking at a bleak future, especially when it comes to limb loss and potentially losing their leg. So ideally, we want to identify patients who may be candidates for the procedure we're going to talk through tonight. This is a transcatheter arterialization of the deep veins, a TADV procedure. So the sooner we identify who these patients are, we can get them into treatment appropriately. So these are the things we want you to look for. A patient that may have a non-healing wound of 2 weeks or more, or they have this small artery disease we talked about with the medial artery calcifications, or they're patients that really are looking at an imminent limb loss. They don't have any regular interventions that would help save the foot. So when we are able to identify these types of patients, we get them in for treatment. So what we'd like you to think about is a ASAP principle, ASAP, where one, a patient who is at high amputation risk. This is a patient who's had failed previous revascularization and are basically at imminent limb loss. Or S, for skin changes. These are non-healing ischemic wounds or have the associated skin changes that go along with arterial insufficiency. Next, the A is for anatomy. If you can see it on an X-ray, they have small artery disease due to the calcification of the vessels, and we know they're at greater risk. And finally, the patient factors. These are people who have multiple comorbidities that make their health at risk anyway, and really it make them less likely to be managed by other more traditional interventions. The ideal patient for the type of procedure we're talking about tonight are patients that have wounds of the forefoot. The reason is the goal of this procedure is to bring arterial blood into the foot through the venous system. So we need to have an intact venous pedal loop to be able to get the blood to. So if the wound is in the midfoot, or if something has been done to as type of an amputation that may have affected this region, they're really not candidates for this type of procedure. So ideally, patients who have forefoot gangrenous changes or chronic wounds are the ones who are best candidates for this procedure. And it's also important to think of if you are going to be doing any type of amputation or debridements, we need to keep that midfoot vascular anatomy intact. So when we're looking at patients like this, you want to find patients that have non-healing wounds, pedal calcification, possibly multiple failed previous interventions. You want to be able to get these patients into a treating interventionist as soon as possible, and think about the ASAP framework. Ideally, patients who have forefoot wounds or gangrenous changes are ideal for this, and being mindful that the midfoot deep veins need to be preserved. And the sooner we can get these patients in for treatment, the better. So next, I'd like to turn it over to Dr. Michael Siah, who will talk about the procedure itself. Michael?
Thanks so much, Dr. Evans. Before I get started, I'd like to thank ALPS in particular, because I was lucky enough to be a recipient of the ALPS Traveling Fellowship. And the reason why I sought out that opportunity was because I had so many questions about the arterialization of deep veins. And I took the opportunity to actually go to Italy and work and spend some time with the godfather of DVA or TADV in Roberto Ferraresi. So I think the only reason why I have any insights in talking about this procedure the way I can today is because of ALPS. So thank you. Next slide. I don't think I ever got control. So Dr. Evans talked a lot about TADV, so the transcatheter arterialization of the deep venous system. And it's essentially a fancy way to describe what this procedure is trying to do. These patients who have very, very advanced peripheral vascular disease, they've got such severe blockages of the arteries of their calf and the arteries below their ankle. What a TADV does is it creates a connection between the arterial system and the calf and uses, rather than arteries that we've done historically, that's the conventional way we open up blood vessels and get oxygenated blood to the foot, it leverages the venous system. So that connection between an artery and a vein in the calf is a new pathway to deliver blood, oxygenated blood with nutrients to the foot to mitigate the risk of amputation. So unfortunately, this video isn't going to work tonight, but the cartoon that you can see on the right is sort of an X-ray image of what a TADV actually is in practicality. And the thing that makes a TADV so special is it is the proprietary LimFlow system, which is the only FDA-approved sort of kit that's purpose-built to facilitate this connection. And the thing that makes this kit so special is it has a system or series of devices that allow you to cross from the artery into its corresponding tibial vein. After you've made that connection, or what we call a fistula, you're able to advance a wire from the arterial system into the venous system, into the foot. Now, the second tool that they have is a forward-cutting valvulotome. And veins aren't supposed to allow for blood to flow towards the toes, so this valvulotome facilitates that. And the last component that really differentiates it from all the other techniques, whether they're minimally invasive techniques or open surgical techniques, are the two different types of stents that come in the system. There's one parallel sort of cylindrical stent, which is very similar to stents that we use elsewhere in the body. But the true differentiating stent is the tapered conical stent, which is smaller in the arterial portion and larger in the venous portion. And I think those components are what make up the LimFlow, and I think have made it my go-to therapy or my go-to system when I think about doing DVA or TADV. Next slide. So when I talk to my patients about this procedure, I'm lucky enough to sit next to a foot and ankle surgeon who I trust. We've done a lot of these procedures together. And I know that my portion of the procedure, the actual TADV, is the easiest part of this patient's journey towards amputation prevention. My procedure on average takes around 2 hours or 120 minutes. But these patients, not only do we need to identify these patients earlier, but these patients need to undergo the procedure, and then we need to work together, not only with the patient and the foot and ankle surgeon, but their family and their family units, as well as sort of the whole armamentarium that goes into wound care to get these patients from post-op day 1 after TADV, ultimately out to 3 to 6 months where their wounds are completely healed. And that requires a lot of follow-up, that requires a lot of ultrasounds, that requires a true multidisciplinary approach that, you know, you can get success when you're doing conventional procedures, whether they're bypasses or angioplasties, sort of acting like a lone ranger. But when you're tackling the sickest of the sick, the most challenging of the challenging, you really need to do it with a team. Go to the next slide. So if you look at the left and you remember some of the angiograms that Dr. Evans showed, we didn't see a lot of blood vessels that were open at the level of the ankle or beyond the ankle. And you can see that on the image in the top left-hand corner. Now we do angiograms, or at least I do angiograms of patients with these types of angiographic findings with a whole variety of presentations of tissue loss. Some patients can have an entirely gangrenous forefoot. Some patients can have an isolated heel ulceration. And some people can ultimately just have a distal tip digital gangrene, right? An angiogram is never going to give you macroscopic information on what a wound is going to look like. And you can see with all the pictures on the right-hand side, you can see what can happen and what you can achieve after TADV. You can get a TMA to heal. You can get heel ulcers to heal. Patients don't need to go on to get a TMA and ultimately can only undergo a minor amputation of a single digit. And sometimes their wounds can heal by themselves without any minor amputations. So there are a lot of different expectations that I think have been propagated through conversations amongst people about what happens to patients and what types of results you'll get. But we've seen that not every patient gets a TMA. In fact, sometimes they can heal primarily. You go to the next slide. And I think this slide is incredibly powerful because this therapy, DVA, TADV, it's not something that a couple of cowboys are doing all over the country. No, this is a therapy that's been recognized to be efficacious enough to be in guidelines. And you can see on the right-hand side, it is published as a therapy. It's a recommendation in the 2024 Journal of American Heart or Journal of American College of Cardiology in their guidelines for the management of lower extremity peripheral arterial disease. So the body of evidence to support this therapy continues to grow, so much so that we as interventionalists recognize that it's a therapy that should be offered to patients who are deemed to be no option. Go to the next slide. So Dr. Evans talked a little bit about who is a no option patient. And, you know, my definition has changed over time from the perspective that I have as a vascular surgeon, right? And unfortunately, despite winning the ALPS scholarship and getting to go spend some time in Italy, the definition is a little bit more nebulous to me today than it was 2-3 years ago, right? And I think that's because no option means multiple things to multiple peoples. Obviously, we've seen the angiograms. Anatomic sort of pathologies can contribute to a patient being no option. If they don't have a target for bypass, or there's simply nothing you can open in the foot, those patients are no option. But additionally, there are patient factors that can go into who is a no option patient. Some patients have a history of DVT, right? And those patients have such extensive DVTs that their venous system is occluded and you're not able to leverage their venous system, those patients could be considered no option. Their their physiologic components like heart failure, these patients can't lie down flat. They can't tolerate general surgery. These patients aren't potential candidates for open surgical bypass as a result of that. So those patients could also be considered no option as well. And the elephant in the room, at least from an interventional perspective, is skill level, right? Not everybody can do complex arterial reconstruction procedures. But because when you do a TADV, you're leveraging an open, healthy venous system, one might make the argument that these procedures are actually easier to do than a complex pedal reintervention. So all of these things go into my definition of who a no option patient is and who's a potential candidate for this therapy. Next slide. Right. We're going to talk a little bit more about data, and the data that really guides this therapy are the PROMISE trials, right? In the PROMISE trial, the way in which no option patients were delineated were an individual interventionalist would identify a patient as no option based upon the absence of a lack of target for bypass or endovascular surgery. But beyond that, somebody else, an additional group of sort of investigators, looked at those angiograms and corroborated that those patients were in fact no option, right? But in addition to that, Dr. Evans, you talked about this a little bit. We've all seen patients where someone, whether it's myself or another interventionalist, has done everything we can to optimize someone's perfusion, but in spite of that, wounds don't heal, right? Those are failed interventions. Sometimes these patients have persistent rest pain, despite our best efforts. That's a failed intervention, right? In those scenarios, those patients should be considered no option as well. Next slide. So the PROMISE 2 trial is sort of the seminal paper that has really pushed the adoption of this therapy forward in the US, right? And that was a prospective single-arm, non-randomized trial that looked at 105 patients who underwent TADV at 20 sites in the US, right? And the results were very impressive. We have to remember the substrate of the patients that were enrolled into this trial were patients who would otherwise get an amputation. And in these patients, not only was TADV, the actual procedure, performed successfully almost 100% of the time, at 6 months, these patients, greater than 75% of the time, not only did they have limb salvage, but they were healing or healed, right? Which is incredibly impressive when we think about where these patients were coming from. And I think Dr. Lepow, you said it really eloquently when you said this once no option patient population has truly been given a second chance at life and limb. And I think that the 1-year data, which we're about to show, and we can go to the next slide, is really, really impressive because that greater than 70% limb salvage in these patients, or 75% at 6 months, 71% at 1 year, and that remains stable out to 2 years in these PROMISE patients. And the second line, the line below it, was a subset of patients that were looked at who were deemed to be no option, but this therapy was actually withheld from them. These patients weren't allowed to undergo DVA because we wanted to understand or get a better idea of what the natural history of these patients are. And the limb salvage rate in patients who are deemed to be no option, who don't undergo TADV, is 51% at a year. So it's very obvious that this therapy is doing a lot for patients who would otherwise go on to get amputation. And with that, I'd like to transition to Dr. Shin. Thank you.
I would also like to say thank you for having me on today, both to Inari for supporting this and for ALPS. It has been quite a journey. I'm over at USC, and I also wanted to make a plug. This is an incredible meeting. We do it every year. This year it'll be in beautiful Anaheim, October 23rd to 25th. It's a really great opportunity for a lot of these different groups to come together. Oftentimes, I talk to podiatrists from all over the country. They're like, I really have difficulty reaching out to vascular surgeons. I really have difficulty reaching out to interventional cardiologists. And sometimes you feel like you're in this silo. So when we have webinars like this, when we have opportunities to have meetings together, it's really this great exchange of of ideas because, oftentimes I have vascular surgeons who think that the only amputations that are available are sometimes below knee amputations. And we talk about these different limb salvage routes, and to develop these teams and to show these different models, especially from a healthcare system, especially because we're trying to get this new technology sort of implemented in these different ways. Sometimes you can't do it at your community hospital. Sometimes you can't do it in your private practice. So you look for opportunities to kind of reach out, to kind of broaden that network to really help your patients out. And so that's a great really opportunity. And so hopefully we'll see you there. And I will talk a little bit about the trials and tribulations, and why it's so important to have podiatry involved for these TADV patients. There's so much work that's involved in the procedures, the selection. DVA really has come a long way. There have been some just incredible strides made, especially, with the data coming out from Italy and bringing that to the United States and getting this better technology. But in reality, you really need to watch these patients very carefully. These are not straightforward bypass patients. These are not straightforward patients that you have after angio. They have a lot of sort of interesting quirks. And so we were just going to kind of talk a little bit about this. And one of the things that we've realized at USC is that we have, for every, let's say, one procedure, the podiatrist has to see them probably about 4 times as often. And so we can talk a little bit about the timing. The important thing to understand is that bleeding from these wounds is not terribly uncommon. And what you want to do is you actually want to avoid that sharp debridement for at least 2 weeks. We've had patients before that have had significant bleeding complications because you're pressurizing the system, you're arterializing these systems. And so, whereas we're typically just focused on these like main arteries, now any sort of venous entry, and especially as these patients start to develop these collaterals, they can actually have significant bleeding. Wound healing after these procedures may take several months, and this close collaboration is important because this dry gangrene may start to convert to wet gangrene. You may have to intervene. There are a lot of discussions along the way, and oftentimes these wounds can actually look a little bit worse. And so because understanding that this is a really high flow fistula, you're changing the anatomy, you're changing all of this, making sure that these patients that have these underlying conditions, this history of heart failure, hypotension, we want to make sure that they're being watched, they're being monitored. We actually work very closely with the cardiologist to see if there's ways that we can supplement these patients so that we won't have any hemodynamic issues. Next slide. One of the things that we have to sort of reiterate over and over again, and this is a conversation that we have not only with our staff, but also with this acute care setting, is you really want to avoid any pressure cuffs or any tourniquet use. And that even includes things of that nature of these non-invasive arterial exams. What you want to do is you want to make sure that you're not compressing any of these things. You want to allow the system to sort of develop and flourish in place without blocking it. You want to avoid these proximal foot amputations because you want to make sure that you kind of maintain that loop, and you don't want to damage this either this lateral plantar vein or these perforators, and you want to try to keep as much of it as intact as possible. And that's really hard because you see tissue that looks dead, typical tissue that you're normally debriding back further and further. But again, you have to understand these patients really didn't have a lot of options to begin with. And so when you see these patients, you want to allow this tissue to start sort of healing from the inside out. You want to allow this vasculature to come in place. So negative pressure wound therapy is not contraindicated, but you want to make sure that you use sort of a lower pressure, and you want to give it some time for this to mature and some time to not have active bleeding. And then you also want to have a plan for bleeding. Are you going to use different sort of hemostatic agents instead of compression? Are there other types of coagulant products to use? Next slide. One of the things that is so essential whenever you have this patient selection or have this discussion with these patients is that the pain may not necessarily go away. And that with any types of open wounds, with any types of limb salvage, the things that we're monitoring for are, we're looking at pain, we're looking at infection. Again, these wounds sometimes look worse, especially because they kind of develop this sort of venous hypertension. They have this tissue discoloration. And so you'll experience a different type of pain. So sometimes these patients feel this post-perfusion pain afterwards. And a lot of times we have to talk to them. We have to discuss different pain management strategies. It's really important to let them know that, hey, this isn't just a one and done deal. This is really, these are, it's advanced technology that we're utilizing to try to really, prevent these proximal amputations. Careful debridement, of course, only to resect any like necrotic tissue, again, not kind of cutting too far back. And the really two drivers for anything early intervention wise is like a kind of gross infection and extreme pain, but we try to avoid that as much as possible. Next slide. So these are types of swelling that you'll see. You'll have these patients that have sort of this enlarged lower extremity. It actually means that the sign that the blood flow is actually getting to the foot. Now, you don't want to completely not treat the edema. You have to talk to the patients about elevation. You have to talk to them about light compression. So you're using sort of a minimal amount of compression with either some sort of low press wrap, and also to make sure that these patients aren't overdoing it for this initial period of time. Next slide. Patients, because they experience this different type of pain afterwards, and it's also due to edema, again, post-perfusion, a lot of times we'll actually get our pain team involved. So using either regional anesthetics, using some sort of injection, or you can do this early sort of decompression, these open TMAs or these guillotine TMAs if it's really the tissue that's causing them to have a lot of pain. We've actually worked very closely with our pain management specialists, and what we found was that narcotic medication isn't necessarily the most useful in this situation. We have to kind of use sort of this multimodality approach where we're addressing the nerve issues, we're using other types of pain medicine in conjunction with these injections to really help these patients kind of get through this acute period. Severe pain should resolve within this 24 to 48-hour period, but you want to make sure that we're sort of monitoring it. And then, so for that period of time, we actually sometimes admit these patients afterwards so that we can see right away if something is going down or if there's some sort of intervention that needs to be, that's warranted early on. Next slide. So this management of anticoagulation therapy is essential. It's this kind of continuation of this dual antiplatelet therapy. And this is a conversation I have a lot with our podiatric surgeons because understanding that these patients are going to bleed when you do these amputations and sort of having that plan in place. And in fact, it's a positive thing, but it can be scary. And you're not using tourniquets. You're sort of leaving these things open. You're allowing them to bleed. You're addressing it through electrocautery cautiously. You're not cutting back, but it's really important to try to keep them on this for as long as possible, at least in the initial stages while this is developing. Early ambulation and rehabilitation, we want to make sure that these patients are walking. Again, we're sort of pressurizing the system. We're allowing the system to kind of work and develop, and having these consultations. So getting these consultants in early on. The TADV is a perfect example of this like beautiful team approach. You're really coordinating, you're having these conversations because again, these are the patients that are at the highest risk of having really proximal amputations. A lot of times these patients have very few options below knee and even above knee amputations. And so kind of keeping that in mind and understanding that these patients really are sort of, you know, these no options or these worst of the worst, or they've gone to 6 or 7 different providers and you're actually able to provide this option for them is really important to understand. Next slide. And so primary closure is actually not recommended for these TADV patients. And this is something we have a lot of discussions, especially with our trainees. We're taught to, you know, you have this piece of skin, you have these beautiful flaps planarly, but a lot of times the compressibility of these arterialized veins actually don't do very well in this situation. And so I'll show you some examples of some open transmetatarsal amputations that we've done, that Brian has done, Dr. Lepow has done. We've sort of written a lot about this because it was initially sort of like it's shocking to leave an amputation that has a flap that's viable, but there are a lot of complications that can arise from doing these closures too soon. Next slide. This is an example of a TMA that was done, and you can see sort of like the necrosis of the skin edges. And what ends up happening is that tissue starts to die back. You worry about that. You have to go and kind of redo the debridement. Next slide. And these are sort of examples of areas where you can actually see sort of this rapid deterioration. So when you actually start to see this tissue turn, it doesn't kind of stabilize over time. That 12 days later follow-up, that sort of discoloration, that kind of darkened discoloration, is not entirely uncommon with these patients post-procedure. Again, you're pressurizing the system, you're bringing a lot of blood flow there, and then there are times where we actually have to go back and our vascular counterparts have to go in and ligate different veins and have to address different sort of outflow as well. So looking at and monitoring these patients and making sure that you're seeing them sort of on a weekly basis is really important, because you have to make that decision of whether or not are they deteriorating because there's something wrong with this procedure itself, or are there other sort of adjunct procedures that need to be done. Next slide. And so this is an example for some of our patients with stage debridements. This is a person that had a 4-foot gangrene, and this is the sort of this open transmetatarsal amputation or a guillotine amputation. And what we do is we cut these bones back, we get to sort of this like nice, healthy, viable tissue, but we leave that sort of plantar aspect fairly long. I stage these procedures out. I use a combination of different antibiotic beads to make sure that we have infection control. And there's a variety of different grafts that you can use sort of in the interim to help with the bone coverage. And at this stage, you can use this like low pressure, negative pressure wound therapy device. Next slide. And so this is another example of some of our patients with this stage debridement. Again, you can see that there's sort of this odd discoloration. And this is an example of a patient that we actually waited a pretty long time to do any primary closure on. And so we actually had to open up some of that dorsal aspect because it didn't heal quite well. And so despite the fact that we sort of waited, we sort of staged it out, they still had this wound care that we had to provide afterwards. And this is a patient that's about only about 8 weeks out from the TADV procedure. Next slide. And so these are another sort of example of some of the different types of guillotine amputations we have. We have the different grafts that we utilize to help build that granulation tissue. These are some split thickness skin grafts that we use. And you can see that we actually are able to maintain a lot of length. Traditionally, a lot of the transmetatarsal amputations require you to have, a fairly large plantar flap. But when you do these guillotine amputations or these straight amputations, you're actually able to maintain some of that length and kind of keep it viable and actually kind of maintain that biomechanical advantage. Next slide. And so this is an example of our hybrid suite at USC. And so this is where we do a combination of our toe and flow. And so we let our anesthesiologists know, we have the whole team sort of on board and we stage it out. And if the patient is undergoing a bypass, we talk to them about sort of the timing of amputation. Sometimes we will plan for these amputations within 2 to 3 weeks of the procedure. We'll also do these angio-guided amputations. And so using the information that we get from these angios, we can actually sort of target different ways that we are not cutting into the blood flow. We can see if these patients are actually capable of not even doing a transmetatarsal amputation, but maybe just a digital amputation. And then we look and see and really have this conversation with the patients that, hey, these interventions may not last forever, but if they last long enough for us to heal the wound, that's like sort of the most important thing. And so far, we've done about 13 of these procedures at our institution. And I highlight this because it's humbling and it sort of highlights the fact that we have to keep researching this. We have to keep looking at opportunities. The overall high-low, so the high amputation to low amputation sort of pre-COVID for us was 0.2, and we were kind of patting ourselves on the back and we thought, hey, we're doing a great job. And then peri-COVID, when a lot of these patients had difficulty with follow-up and a lot of these different complications, that number really jumped up. And so, any institution, even institutions that have buy-in, that have multiple vascular surgeons, multiple podiatric surgeons, these numbers can change. And these patients can really have these like just catastrophic events with this limb loss. And so it just highlights how important what we do is on a regular basis and why we're so motivated to kind of keep pushing that envelope so that we can keep doing a better job for our patients. Next slide. And so for the first 6 weeks, it's all about patients. I have patients that complain to me on a regular basis, they say, this looks terrible. I thought this was going to look better. And it is a lot about, communicating, educating, showing the patients, hey, that these are the things that are involved. And again, it's this team effort, like, yes, we did this procedure. This is not something that is straightforward. There is no sort of like pathway that we know. Everyone heals a little bit differently. But we try to get this healing, or at least this improvement in healing, within the 6-week period. And then we go from there. And multidisciplinary patient care and communication is really essential. Other than my husband, I like my second, third, fourth, fifth on my speed dial are the vascular surgeons in the area and people that I talk to on a regular basis, and infectious disease and physical therapy, just to make sure that we're maintaining that communication. Next slide. And so I will bring it back to you, Brian.
Excellent. Look, this has been really wonderful. Before I get to some of the conclusion slides, I do want to just recognize all of our panelists today, Dr. Siah, Dr. Shin, and Dr. Evans. Really, really a fantastic job. Oh, hold on. Put that slide back up, Ann. AK. Just got to finish up a little conclusion there. I will get to conclusions, and then also a quick reminder while we're getting those slides back up. If anybody has questions, please feel free to put it in the Q&A chat. There is an area section here where you can add some questions in, and then we will get through some of these questions as we go through things. Just to kind of round things off, the patients who undergo the TADV procedure experienced a 76% wound healing rate and 76% limb salvage rate at 6 months, as demonstrated in the PROMISE 2 pivotal trial study. And I must say that was really a landmark study that I was really privileged to be a part of when I was at Baylor College of Medicine with my Flo Miguel Montero Baker. This is really where I was introduced to the TADV procedure by LimFlow, and really noticed that there is an opportunity to make a difference in a population of patients that otherwise didn't really have an option or were facing amputation. So it led to both the FDA clearance and the commercialization of the procedure. So really, really groundbreaking study. Early identification of the candidates is really essential. And as we're starting to learn here, more and more patients, I think we can get to them a little bit earlier than later. I think some of us kind of wait too late till there's too much tissue loss, and it's a lot harder to come back and reconstruct those feet. TADV patient journey does require a long-term collaborative effort spanning several months and spanning multiple specialties. It's not just vascular podiatry. We tend to think that it's really a toe and flow model, and yes, there is some of that, but honestly, a lot of this is including infectious disease partners, physical therapy, mental health counselors. I think there's a lot of different entities that are necessary to kind of help make that patient journey a successful one. And again, effective multidisciplinary communication is key. And I can't really emphasize that enough. Having working in siloed entities is a really challenge with this type of procedure. And I think this is where TADV and LimFlow have really made a huge difference in looking to sort of showcase where collaborative efforts can work best. And I truly believe that is for this procedure. And just to kind of end things before we got a flood of questions coming in, so I want to make sure I get to everybody's questions, but I again wanted to acknowledge both Stryker and Inari LimFlow for their support for this. I think it's a really interesting sort of a new procedure that's come to the forefront and is really changing the landscape for a population of patients that otherwise really had no other choice but an amputation. And I think this will make a change in generations of patients moving forward. And I think all of us who are involved with TADV procedures, deep vein arterialization, have seen where this is, it's not just a new atherectomy device or a new way of getting, opening up a clogged artery. This is really a game-changing procedure that is making a difference in many of us. And then lastly, to the ALPS team, thank you so much. This has just been really a great opportunity. This is just showcasing some of the toe and flow team. We see each other often, but honestly, we see each other annually at DEF CON, and that's really just a great event, as Dr. Shin mentioned, for just collaborative efforts amongst many different specialties, not just vascular podiatry. PT is there, nursing, IED specialists. People come from all over the world, and it is really a great opportunity to have more in-depth conversations and to learn more. And I think for most of us that are out there on the lecture circuit and attending lectures, that TADV is now everywhere. every conference you go to, there's either a lecture or a tract or a workshop dedicated to it. So this is something that's not going away. It will be with us for the future, and we're all fortunate to be part of that. So thank you all today for your time. I think there is one quick slide here, just safety information. We could pass through that. And I don't know if there's another slide here. And then again, just a reminder, you could join ALPS today for $1 if you use this code CLTI. Click on the link there, and then look forward to the 25th anniversary of DEF CON. That's a major milestone. Many of us have been present, like myself, really since day one of DEF CON. So to see and to be part of it 25 years later is pretty awesome. And kudos to Dr. Armstrong and really the team, for really, this conference has come a long way. I think the last one we were at last year had over 500 plus attendees. And that's pretty amazing, from where things started. So, it's more of like a family environment, which is really unique for these types of conference settings. So I really encourage you to sign up, come, talk, share your experiences, share your cases, get involved. It's one thing to sit and complain about the things that aren't getting done. It's another thing to do something, get involved. And I think that's where everybody can make a true difference. So with that, I will turn the page and answer questions here. We'll jump right into the chat here. We have a question from, let's see, I believe Dr. Sherman. It says here, I know when we evaluate these cases, the steal phenomenon often sometimes come into play. Can you expand upon the significance of that? And I'll put that out to Dr. Siah, Dr. Evans, Dr. Shin, if anybody wants to chime in there.
Yeah. Okay. So I think one of the issues with where we are with TADV is anecdotal experiences really drive the narrative on what to expect in the postoperative sort of period following TADV. So one of the things that we talk about is the steal phenomenon, which, depending on what you read, encompasses swelling and sort of intractable pain following these procedures. So I don't think steal phenomenon can occur, but I think it doesn't occur because you've created a TADV, but more so steal phenomenon is occurring because the way in which this procedure is performed, ultimately, when you put a stent from an artery into the vein, all the perfusion that artery did prior to placing that stent in, everything beyond the stent is now taken away suddenly. So I think patients can have a tremendous amount of postoperative pain if you use your donor artery, the artery that connects to the vein. If that artery was something that contributed a large amount of blood to the foot, now after placing the stent, these patients are going to be in a tremendous amount of pain because you've iatrogenically caused ischemia, right? So I think the way to avoid that is by choosing an artery that contributes the least or less than another artery and trying to preserve. When you're doing a TADV, I try to do everything I possibly can to preserve their baseline perfusion so that the TADV is additive and not something that subtracts anything. And in doing that, I'd say 99% of my patients in the last year or so, if I'm able to preserve their baseline perfusion, they go home post-op day one and most of them don't have pain. Whereas prior to that, I thought you wanted to take their largest blood vessel, the one that could accommodate a 3.5 or 5 millimeter stent. And in those patients, my early experience, before I was doing TADV and I was doing these off the shelf, all those patients, like my residents and fellows will tell you, like they all were in the hospital for a week or two because they had horrible pain. So that's what I think is going on with steal. And that is something that an interventionalist can plan their operation to avoid. So I think steal is something that hopefully one day will be a lot less prominent in the discussions people have in adopting this therapy because it'll be clear. And we presented a poster at the vascular annual meeting. A publication is on its way that's going to enumerate how steal manifests with pain and how that can be changed based on how you do the procedure.
That's awesome. Great. We got a flood of questions coming in. I'll head into the next question. This is probably for the TOE team, but we'll toss it out to Dr. Siah as well. What makes wound management more difficult than traditional revascularized patients?
Well, I think Brian and Laura, you guys can chime in on this because you guys are doing this too. But I would say that unlike everything we do prior to doing TADV, right? You do a bypass, you expect the patient's pain to go away in their foot. Maybe they'll have incisional pain or something. Or you do a balloon angioplasty, put a stent in. We expect patients after that to improve. But the fundamental mechanism of TADV is to use a vein that needs to turn into an artery, and it takes time, right? So rather than chopping off the dead and necrotic tissue and closing patients to prevent, infection, bony infection, persistence of infection, you've got to wait. And that's a paradigm shift in the way these patients are managed. And I think that's the reason why these patients are so difficult, because we've applied the way we used to look at these patients into what we're doing now, which is fundamentally different. And I think that's the reason why. I think another question is why you can't primary toe amputation. I have no idea what the substrate were in patients that were able to heal primarily or heal with minor amputations. The only thing that I'd suggest goes back to the steel thing. If you preserve their baseline perfusion, most people don't present with a desert foot with their whole foot is gangrenous, right? An angiogram doesn't always show us what the actual tissue perfusion is. So that's one of the reasons why I think the management is different. And then obviously why these patients are healing primarily. What do you guys think, Brian, Laura, John?
I think that, I think it's just something that we're all trying to get used to, right? And I think that while I think the conversation has been don't close the wounds, what I have seen is in some of those that are out 4 to 6 months and have already converted over or their DVA has matured, then maybe you can consider a low tension closure. We've been moving towards some of that in some of our patients. But I can tell you, I had this conversation with a lot of people that are involved, or new operators and those that have been doing it for a while. I think the majority of the success of our cases have been open guillotine amps, and they're much more predictable to follow through. Now, I know that sounds radical to do, and somebody may have an isolator or two toe gangrene, but my response to that is, well, these are patients that are already been told they're going to lose the leg. And so I think getting them into diabetic foot remission as quickly as possible, 3 months or less, is the goal for most of these patients. And if you're taking the toes to save the leg, then I would find that as being very successful. And so I think that most of my experience in terms of a short term for healing has been with these more aggressive open amputations. The ones that have closed really have all kind of maybe stayed closed for a short period of time, but have wound up opening up or needing to go back to open up. And so now you're kind of just going through that cycle again of another operating room visit, delaying the healing. And so this is kind of where my thought in being overly aggressive early gets these patients to the finish line much faster.
I would like to add one thought on this. All our interventions up to this point, for the last 100 or so years have been aimed at improving the arterial blood flow into the foot. This is different. This is basically trying to trick the foot into recognizing that the blood's going to come in from the venous side. So I think the whole system has to stabilize itself because it's just different. And so those of us that have been doing limb preservation for a long time, we really have to rethink how we're treating these patients because they do heal in a different manner. The best time to do a primary closure procedure is not immediately after the intervention like we do for arterial procedures, because that's when the blood flows the best. This is totally different. And I think we need to consider that when we're treating it and deciding the best way of dealing with these.
I will move on. Go ahead, Dr. Shin, please.
Oh, I was just saying, so a lot of times what happens is that we get end stage gangrene, and it depends on patient selection. And I noticed out of Italy, people were intervening a lot sooner before they had this massive amount of tissue loss. For us, it is really difficult when somebody gets a primary amp without any intervention, and then the complications or the sequela afterwards is the reason why we get them. And so, we're playing a little bit of catch up, but I totally agree. Sometimes you just have to sit on it. You have to just get infection control, use antimicrobial dressings, get them on antibiotics, and then just wait it out.
Yeah, totally agree. We may have time for one more question. I would like to say that all those that have sent in questions, what we could probably do is get that sent out to the group and we can answer these questions offline. We got about 10 questions left here, but I think I can only get to one more. And that comes from Dr. Suzuki. And does it matter if these patients have existing venous disease prior to having a TADV performed?
So I think the challenging thing about the presence or absence of venous disease in this patient population is, right, we're either thinking about DVTs, which we may have information on a patient with CLI or CLTI. We may have a duplex from the hospital that shows that they've got a history of DVTs. And no one's done a subset analysis to determine whether or not DVT is either going to be a bad thing or a good thing. Obviously, if their plantar veins are occluded, you can't do this procedure. But the other thing that contributes to chronic venous insufficiency and high SEEP scores or venous ulceration, right, is venous insufficiency. We don't have like CLTI patients don't get reflux studies routinely before we do these procedures. And for me, in all the DVAs that I've done and all the TADVs, I've never done a reflux study in anticipation of doing a TADV. But when I sit there and think, because I've thought about this before, right? Venous reflux means your veins are incompetent, which means blood is going to flow more easily through the veins if you've arterialized them. Maybe we might see tissue perfusion. Maybe we might see faster rates of wound healing. You know, these are all purely hypothetical sort of conjecture, but that's just based mechanistically on the physiology of the venous system. So I'd hypothesize that potentially venous insufficiency is a good thing. You're going to get venous insufficiency if you have a chronic popliteal vein DVT. Maybe it might be a good thing. I don't know. That's a great question. That's something that your experience is going to help guide our therapy, right? Because that's where we are with DVA and TADV. It's like we need to do more.
Well, with that, it is 7:01. We are a minute over. I think we've done a great job. Thank you all again to the panelists, to DEF CON, to ALPS, and to Stryker Inari LimFlow for your support. And thank you all for your engagement. We have a list of great questions here. And again, I'll make sure we try to get these out to the panelists and see how we can get responses to you. But again, thank you all for being engaged. And we look forward to seeing either you at DEF CON 25, if not for future webinars here on our platform. Thank you so much, and hope everybody has a great evening. Bye, everybody. All right. AK, are we off?
We're still got a few on. Hold up. She's working.